as you just mentioned to me, this patient has metastatic disease now to the lung. By all means, this is a time where the interventional radiologist should sit with the oncologist at the tumor board to pick up the phone and say, maybe it's time to start talking about systemic therapy. And this patient, by all means, should go as a standard care again on sorafenib as a first line of treatment or a clinical trial if readily available at that time. This patient appears to be that their bilirubin, which was totally normal, about 1.0, jumped to about 1.8, which kind of like put them in a category of a higher bilirubin that continues to, again, 2.1 maybe. And their Charge-P score now is right on the edge between A and B, maybe a B7, if let's say the albumin is a little bit low as well. In that scenario, sorafenib is still appropriate, but there is data already published, first author Miller from JCO a few years ago, that showed that actually for a bilirubin between 1.5 to 3 of the upper limit of normal, half the dose of the sorafenib will be appropriate. And this is where maybe a patient like this should be monitored very closely with bilirubin and of course other things, and still be given sorafenib, but with close monitoring. With close monitoring means that patient will be seen probably on weekly basis, have bilirubin checked, and be taught about any symptoms that will probably reflect on increased bilirubin, like for example jaundice, change in the color of urine, yellow eyes, etc. When sorafenib was first approved, there was a certain excitement, and this is a pill, and just give it to the patient and check on them at a certain later point in time. A close follow-up is so critical for patients on sorafenib, and probably is going to be the same for regorafenib patients. You got to make sure that the patient on a regular basis. In the start, when we start therapy, I personally will probably give a call for the patient within 3 to 4 days. Anybody in the office can do that, being the doctor or the nurse, checking, see how things are, because hand-foot syndrome might be evolving at that time, and within a week time, patients should be seen in the clinic as well. It should not be underestimated how critical it is to closely follow up those patients to avoid them from going to grade 3 toxicity, where with really options for them might be limited. And so maximizing on the potential for the therapy by close monitoring and avoiding the worsening of the side effects is critical and of prime importance.